you can just email us at orn@AAAP.org. So AAAP.org. Or you can just call us, 401-270-5900. We'll talk through whatever it is that is on your mind, and we'll do our best to find a good strategy or solution to address your challenge. Next slide, please. All right, folks. So you've heard about enough from me. The three speakers with us today are going to do a lot better job on just sharing than I ever could, as they really talk through the idea of supporting people experiencing homelessness in both treatment and recovery support. So we're gonna approach this as a panel discussion, and I'm going to be posing the questions to all three of our panelists, but I want to introduce each one of them. Ashley Blum is the Director of Homeless Outreach Services at Park Center in Nashville. Sharita Finch is the Executive Director, Sharita, with the Council on Substance Abuse, or NCAD. And then Shannon Knox is the Director of Training and Education with the Los Angeles Community Health Project. And again, of course, I'm Steven Samra. I'm a recovery specialist with C4 Innovations, and I am your moderator today. All right. Sorry, folks, bear with me 1 second. All right. A general reminder before we actually get started, if you've got questions for our presenters, just put them in the chat. We'll do our best to get that question answered. And if you're using the chat today, and we really encourage you to do that, please make sure that you select panelists and attendees so that everybody gets it and everybody sees what you're sharing. And now, if you want to send a private message to an individual or one of the speakers, you can select that individual's name. And with that, I'm going to get us started, folks. So what we're trying to do with our speakers today is to get a sort of sense of the challenges, the strategies, the barriers and the successes of what is happening out on the street right now with folks who are experiencing homelessness and who could really benefit from treatment and recovery. And so I'm going to come at this discussion today by posing just a series of questions. They'll pretty much be open to all of the speakers. If I've got one that is specifically identifying somebody, I'm going to share that as well, directed to that individual, but I'm also going to ask my other panelists to chime in and share a little bit. So with that, let me pose the first question. I'm going to toss this out there, and we'll begin. When we talk about meeting people where they're at, that can mean so many different things. With people experiencing homelessness, how do you interpret that phrase in your service delivery model?
I'll start with that, Steve. That's a great question. I think that one thing that we do at Park Center is look at it from a wide aerial view, right? So it's not just meeting them where they are in their recovery process, but it's actually also meeting them where they're physically located, where they live, if they're in an encampment, under a bridge. It's so important to take care to people as opposed to requiring them to come in for care. We miss a lot of people with that aspect of treatment and of care. So one thing that we do is really meet them where they are, and we go and look for them. We canvass. We also have a street medicine program, and so we're actually taking medicine to the streets. We're taking MAT services to the street, medically assisted treatment to the streets. We're doing telehealth with people via our laptops and things with providers if they can't come out with us. That's how we take it, and that's how we complete our services.
Ashley, thank you so much. Sharita or Shannon, anything to respond?
I think that's great, Ashley. The idea of meeting individuals where they are at. I think we're past the idea that services need to happen in a building, four walls. And I interpret meeting people where they are, going out into the community. And we do some similar outreach, bridges, homeless shelters, in the streets, gas stations. And so I think that's very important because many people we will miss a number of people if we don't use that approach.
Yeah, and for Community Health Project, we're a syringe exchange or a syringe access program. And for us, meeting people where they're at really means having our program, or our participants design our program, listening to what they say and evolving our program based on what our participants are telling us at any given time. And also, I think it's important to say that syringe access and the way that we develop our programming is often considered controversial and also stigmatized. So we also meet our participants on a level of stigma by having somewhat of a stigmatized programming model, because the innovation is what it is. Following the evidence isn't always, up to speed with what common morality would suggest might be right.
Awesome, Shannon. Thank you for that. Thank you, Ashley and Sharita both. So Shannon, this one I'm just going to direct you, because you said when we were doing some content planning, as we were all coming together to figure out what was valuable to share today, you made this great comment that people with substance use disorders need as much intensity in their care as a newly diagnosed cancer patient. Can you just talk a little bit more about that and how it relates to supporting people?
Yeah, so that statement was made in reference specifically to someone who's interested in recovery, but it's not limited to that. Like for people living with addiction and not seeking recovery, they need constant support and care to keep them healthy and alive, and with like an adequate quality of life that we should want for all humans. Stigma keeps the people with substance use disorders from like going to the doctor if they have an abscess or an infection. They don't even have the basic level of care because they're afraid of judgment. And when someone wants to quit using, when someone wants to enter recovery, you need a full spectrum of care, like you would get it somewhere like the elitist Betty Ford Center or something, like a case management intensive, like residential if possible, get them out of their surroundings, and I say this coming from being someone who's lost over 20 friends, not including my syringe service program, to overdose. I feel like it's a class-based genocide, the way that we're not taking care of people and the way that we stigmatize them. And without that level of care that you would see at a 30-day program, people just are not recovering.
Yeah, thank you for that.
And Shannon, I think what we talked about also is this idea if someone, for example, a diabetic that goes to the hospital because their sugar levels or glucose levels are higher, you have health care workers going to that person, trying to address the situation, trying to provide that care. But individuals with a substance use disorder, that response is often different. And so when we talk about the stigma, as professionals, I think sometimes we forget or we subconsciously create that separation ourselves as caregivers. And so for someone who is in need of medical care, I think it is important for us to not place stigma at that time. And just as you mentioned, when someone needs care at that moment and how important holistic health is. I once had a person we served. She said something to the effect that you recover and then your body falls apart. And so this idea that we still have to think about the overall health of an individual as we support them in recovery is important.
I have a little I have a personal approach to this because I'm a cancer survivor. And so I know the level of support and care that I got when I was diagnosed. And so it always felt like I've given really great care to the people that we serve. But after that experience for me 3 years ago, it has shifted the way that I look at care in general. So like I was treated this way, right? And I want to ensure that all of the people that we serve, no matter what they're going through, if they're ready for care, if they're ready for treatment, if they're ready, wherever they are in their journey, I want to give them the same care that I received. So like that newly diagnosed person with cancer, I want to make sure that we are giving that same care to every person, no matter where they are.
Fantastic. Thank you, guys. Because what's coming in this next question I think, just dovetails perfectly. So can you all talk about how person-centered, non-stigmatizing, and non-judgmental conversations with people in active addiction are more productive than some of the coercive conversations that we certainly heard, and some of us may have even used in the past? A threat of job loss, or potentially going to prison, or you need to make 90 meetings in 90 days before I'm going to talk to you about housing. So if the goal is really to explore a person's thoughts about their substance use, and either support them, as Shannon said, perhaps they're not interested in the recovery piece at the moment, but they still are going to need to be treated like a human being and have access to supports and services. So can you all talk a little bit about why it matters to come at this in a strength-based way versus a sort of punitive way?
Well, I just think, do you think that there wasn't coercive conversation that was had with them before their use became so chaotic that they were, then living on the street and alienated? Coercive conversation is what alienates people. It's like, and also if you're a caseworker, you don't want a stranger coming up to you and being like, you would look better if you brushed your hair, or giving you some kind of advice about your life that no one knows why you didn't brush your hair that day. No one knows why you're using drugs, like coming at someone with that judgment and then giving them conditions upon, what it would take to give them that hairbrush type of thing. No one's going to listen to you if you're going to do that. Coercive conversation doesn't work.
Well, I think that from what I've seen is when people decide to come to ask for help, that is one of the most vulnerable times in one's life. And I can't imagine, it's also, I think, in some ways a part of surrendering. And so when you are at that moment and need help, and the fact that the person across from you is not only passing judgment, but also creating conditions for me to access that help. It's kind of like, I'm thinking of, you're in water and you're in a boat and someone can't swim, and you keep moving a little bit further with the life jacket, knowing that that person can't swim. And so they try to go a little bit further, and they try to go a little bit further, and you move the boat a little bit further. And so who wins in this? I just don't know who wins, and how people stay motivated to want to work on themselves and get help. There's a term that I've used before. We forgive ourselves but condemn others. And so as providers, we have to always do, I believe, self-checks on ourselves and question our motives and our agendas as we try to help other people in this field. And so, I think once again, sometimes we are the worst person that a individual in need of support should interface with.
Frida, thank you.
Yeah, and Shannon and Sharita really did a great job answering this. I think that one thing that we do from an organization standpoint, especially our homeless outreach services, is meet people where they are. And I know we've just talked about that, but I just mean like letting them lead their own process. So letting them lead their process, and we are a no wrong door. So if they walk in, or if we, meet them in their encampment and they are not ready for mental health treatment, substance misuse treatment, and they're not ready for any of that, we are still going to be by their side, and we are still going to be present for them. We're going to show up for them, because we don't want to be that wrong door. We don't want to have one more door closed on in people's faces, because they start to get discouraged and not trust the system even more.
All three of you, those are really powerful answers. And I'll just share that in my own sort of recovery journey, it was really stigma, and it was how folks came at me, even people within my recovery community. And I'll just share a quick example. I'd been coordinated into a 12-step program, Narcotics Anonymous. And in that program, I had raised, this was in the mid-90s, and I had raised in that program that I was really struggling with a heroin addiction. And I was really interested because I've been seeing people use methadone, and it looked like those folks seemed to be doing a lot better than the people I was running around with, still actively using. And when I raised that in that meeting, again, it's mid 90s, and, 12-step programs are primarily abstinence based. So you can imagine that, it wasn't met with a lot of enthusiasm. And in fact, it was so bad, the response was so bad that I left the meeting, got high, and then swore that I would never use something like, methadone, because that's just replacing one drug for another. And 3 overdoses later, I decided that I would rather just replace another drug with another drug rather than die. And 21 years later, I'm in front of all of you today as a result of my medication-assisted treatment. It worked, and I share that story because the stigma is what almost killed me. It wasn't the opioid, it was the stigma. So with that, let me move to the next question. What are some common reasons people experiencing homelessness might not make it to things like scheduled appointments? And then how do providers make changes to their approach, their programming, that might make it easier for people to attend?
So I'll start with that one. So if you think about it, if someone's living every single day in like how I'm going to survive mode, like survival mode, and they have to be in one area of town at 10 o'clock to get a meal or a shower, and then their appointment that they are scheduled for their medication management or their therapy or whatever it is that they need to go is across town at 11, but the only time you can get the shower is 10 a.m. over here, and you're pretty far away from each other. They're going to give up that appointment. They're going to give up that care because they need to get their basic needs met. So then they're tagged as, non-compliant or, like they're resistant to treatment kind of thing. And they've got this label put on them and the blame is put on them. So we have this, then we have this continuum, we have the structure of, like our system is failing people, because if they're supposed to be here and then here and then here, and they can't make it to all these appointments. So the way we have structured our services is that we take a lot of people food. We take a lot of people, in Nashville, there's a lot of canteen food trucks that go down to encampments and ensure that people are getting meals so that then they can get to their appointments if they need to go off site. But we're also taking care to people. So we do street rounds on Wednesdays and Thursdays every week, where we take medical providers down to, the people we're serving. So that's helping a lot too. But we need to stop putting the blame on people and start structuring our services to where people are getting their needs met and not having to choose. Because having to make a decision between eating in a med management appointment, more than likely they're going to eat, because nobody can do anything. Sit through an appointment, fill out paperwork if they're hungry, if they're thirsty, if they're hot, if they're dirty, so we have to help them get their needs met. And same, we have shower services that are like little mobile showers that are going around now in Nashville, which is excellent too, to help them get their hygiene needs met as well. So thanks for that question, Steve.
Thank you.
Yeah, and I just think that regardless of anyone's situation, everyone deserves respect and the ability to maintain their dignity. And when you think about dignity and someone who may be homeless, as you mentioned, Ashley, it's not our job to judge. If you're in the helping field, the idea is to help. Some of the things that we do, we actually transport individuals. We actually help people move to places. Think about that. What a novel idea. Someone finds stable housing and they have no way to get to the place. That goes back to meeting with people where they're at. We had an individual who just started a job 2 weeks, and his shift is after 4 o'clock. He lives at the Salvation Army temporarily. And so sometimes those shelters have the hours that you can't, of course, come back, right? And so we talked to the staff and said, this guy, he has a job. He gets off at 6. Can you please give him some leeway? So we had the conversation with them, and we know that sometimes it's hard to finesse those conversations between an individual and a service provider. And so why can't we finesse that conversation? Why can't we be that voice? And once again, meeting people where they at. And so I just think that, even in terms of meetings, it boggles my mind that we expect people to do the things that we wouldn't do. And so whether it's attend a meeting, if someone needs to be at a meeting at 7 o'clock, okay, well, then we're going to have a meeting at 7 o'clock. 8 o'clock, okay, we're going to schedule a meeting at 8 o'clock. And, we have a number of providers, their doors are closed at 4:49. Well, substance use doesn't just stop at 4:49, right? And so it's just amazing to me. We don't bend for others, but we even want the police to bend when we get a ticket, right?
That's Shrita. Thank you.
Yeah, and more of the reasons on top of, what was mentioned before, just like from a person who uses drugs perspective, is you have to understand that on top of everything else, criminalization of being well makes the hustle to stay well a full-time job, from hustling money, maybe flying a sign, maybe stealing a bike and selling it, then finding the drugs, buying the drugs, and the drugs you want, finding a place to hide, not be seen, to inject or ingest the drugs, finding a vein when your veins are collapsed, on top of everything else, and then making it to an appointment. When if you're addicted to heroin, you're doing 3 to 4 shots a day, right? And so this is a 3 to 4 time a day process. Criminalization is a huge barrier to people making it to their appointments. And, there's no simple answer to that one except for advocacy, and consistently staying on top of the advocacy for decrim. That's my answer to that question.
Wow, Shannon, Ashley, and Shrita, all three of you just really had powerful stuff. And as I listened to all three of you, and Shannon, when you were just describing, the really what it takes to stay well, and then try to function. I did a couple of years of college while I was, in active addiction, and I can remember struggling to make sure that I would chip on my supply rather than use it as I normally would, because I couldn't handle not being well enough to go to school, and then to chase it down to find it is a full-time job. It just, it's tremendous work to maintain an addiction. And I don't think people really understand or appreciate how difficult that is. And then when you add all of the other components to that, all of the other demands, the things that, you know, that folks are asking you to do, and then that giant umbrella of the criminalization piece, you know, it's a wonder that anybody recovers, honestly, because there's so much pressure on you. So
And you
anyway,
know what,
sorry.
Steve?
Go ahead. Go ahead.
What I'd like to also just chime in and question, why is it still a new concept to provide holistic services?
That's a really good question. You know, and there's plenty of evidence around, you know, the use of the, you know, the social determinants of health, about, you know, coming at you know, the treatment and recovery in a holistic way, that really, you know, treatment and recovery aren't even separate. It's, you know, treatment, you know, gets you on the, you know, on the path, and then the, you know, the recovery work, you know, supports your sort of evolution as you move along in recovery. And, you know, Shannon has pointed out, not everybody's interested in recovery. And so, you know, how do you support people who are, you know, who may not be interested in recovery and who are still actively using? The challenge is that, you know, we need to be careful not to distill those individuals down to addicts, because behind the, you know, the substance addiction, there's a human being there. And that person has, you know, you are seeing them in a snapshot moment, and there's a whole life behind that individual. And, you know, all of you have pointed out that, you know, you don't know what the experiences have been for this individual. You are just seeing them right now at probably one of the most difficult and vulnerable times for them. So,
well, and it goes back to the notion, you know, I am not my disease.
that's
And
right.
so if we were to be judged by the decisions we make in a snapshot of time, gosh, we would all be in trouble, right? One of the things that we do with our program, our recovery program, we integrate the 8 dimensions of wellness. And so the concept, the idea is not only, of course, recovery is the goal, but like you said, not everyone is ready for that commitment. And so because of that, life still goes on. And so there's the dimension of wellness, there's the dimension of spirituality. And we talk about that balance in terms of a wheel. And so when a car has one tire, you know, flat, that car is not balanced. And so how do we integrate services to balance, to stabilize that individual? Because clearly, if I am if I don't have a roof over my head, I'm unemployed, my health isn't great, do you think I'm really thinking about my recovery? And so the idea of stabilizing and integrating those dimensions of wellness is to balance someone that may promote or prepare them or to ready them for their commitment to long-term recovery. And so, as you mentioned, we're just not one-dimensional humans.
That's right. Shannon or Ashley, any last thoughts before I move on to another question?
I think mine go into the next question.
All right, here we go. All right, let me see what I can pull up here. Often it feels like stopping substance use is the primary goal. I swear these just dovetail perfectly. So it feels like stopping substance use is often the primary goal for treatment and recovery providers. But, you know, someone moving from active use towards care is perhaps the most difficult part of the recovery process. Are there benchmarks, goals that you know, any of your organizations or you personally use internally and with the folks you're serving to sort of measure progress and then success with wellness and recovery? And I guess what I'm asking you is, you know, how do we celebrate some of the, you know, the small successes that we have with folks who may be, you know, waiting for an eternity for things like housing? So thoughts?
Well, I think that an emphasis on recovery being the most essential component to whole person wellness is definitely misguided in my experience. And our program considers maintaining contact our ultimate goal. We don't prioritize recovery just that mantra, any positive change. And that can be for any aspect of a person's life. That's what whole person care is any positive change in a person's life is what we want to see. And at my former needle exchange, San Francisco Drug Users Union, we would hire our participants. And often after that, their other needs, such as access to housing or resources, would naturally come about. Being able to give back, have a schedule, be accountable, be trusted, are huge for people who have been discarded by society, by stigma. And I don't believe that any of those participants that we hired have ever considered recovery yet, but their lives are much better for the ways that they were improved without entering recovery. You know what I mean?
That's awesome, Shannon. That's a really powerful response too that I hadn't quite thought of in that context, honestly. But that is recovery, right? Small improvements in who you are, or the things of your life are that's what we want. That's the beautiful part. And all of our efforts are to improve the lives of our brothers and sisters around us. And whether or not they've decided to stop using or not is not an issue for me. I get it.
Shannon, I love what you just said. Do you think that, for me, I think it's time to decide if addiction is going to be a chronic disease or not in this field. Because if we're going to accept that addiction is a chronic disease, then we're going to have to treat it as we treat other chronic diseases. For example, I'm just thinking about obesity. When you see the doctor, and he may say, well, just start walking 5 steps a day, or just, on certain days, stop drinking soda. It is it's not a, let's do 100 sit-ups every day right away, and so why won't we do that? Why wouldn't we do that for someone who is trying to obtain recovery? We're expecting a miracle, I guess I could say, when we're talking about someone using, and then when we're talking about other people who have other chronic diseases, once again, the expectation is a little bit stagnated, or what's the word I'm looking for, in steps. And so that was just interesting what you just said.
I just want to say real quick, the chronic disease part of it is that I don't believe that people who use drugs could have it any worse than they do right now in the United States. And will it be a chronic disease if we actually followed evidence and implemented better drug policy? Like right now it might be chronic, but it might not be forever if there was actually viable recovery options that I wouldn't be embarrassed to send my participant to and put them through the trauma that they would experience going into some of these centers. So I don't think that it has to be chronic, but I think right now it's the worst that could possibly be for these people.
Good point.
Ashley, anything to add?
Yeah, I mean, I think they did a great job with this one, but I think that one thing that, so today I was asked, what does success look like in your program? And I just want to say that it's so, and this was my answer, that it's just so different for everyone, right? Everyone is going to have, so if someone is in active use and their main goal is to get an ID, it is so successful for us to get them that ID. And we are literally going to go with them down their path next to them, because our program, now, yes, we do have an IOP program in our organization, and we have substance use, we have day program, we have other things inside our organization, but our program is designed to walk with people down their path. And if stopping to get that ID, stopping to get their birth certificate, stopping to get food stamps is what they need, then that's what we're going to do. I can give this example. This is a great success story to share, but it goes along with this. We had someone who was not interested in getting housed, was not interested in any type of mental health treatment, And we first engaged this person while we were doing street rounds. And he just continued to say, like, all I need is a shower. And so for like 7 or 8 weeks, all I did with him was pick him up and bring him in to get a shower and to do his laundry. And the longer we built a relationship, built rapport, built like the trust, then he started asking, okay, remember how I told you that this, and this happened to me while I was in prison? Like, I want to start talking about it. I want to start talking, And so then we started, the doctor started meeting with him out in his encampment. And we started being able to do all these things with him. He ended up getting on like some MAT treatment. He was sober for like 5 or 6 months, which was like great. I mean, he was so happy and he was like so proud of himself. And and we were able to build records so that we could get him on disability benefits. And he ended up getting approved for his disability and hadn't been in treatment for 25 plus years, been on the streets in and out of prison for 25 plus years. And now he's housed. And that's just kind of like the epitome of like starting where people want to start and us not putting them in a box and not saying, oh, the only way you can work with us is if you want this or this, So that's an approach we take.
That's awesome, Ashley. One of the things that we do is sit down with the individual to create what we call a recovery plan. And there's short-term goals and something as simple as getting a driver's license. Because I think sometimes we think a goal should be this big, huge thing that intimidates people. And when they feel they don't reach it, they accomplish it, then they feel like a failure or they don't try again. And so having those small wins and fairly soon has seemed to be very helpful working with individuals. When you talked about your client, I think about one that we've worked with for a number of years from out of state and has been sleeping in laundromats and very intelligent guy, older guy, and trying to get him to get to treatment, schedule an appointment, the assessment, the bed, everything. And so would never show up or, over 2 years. And so most recently, we were able to get him into a treatment program. And I think the only thing that was the difference this time was that we had 2 staff members willing to wait for him and sit with him during his admission. And so when I think about how scary that time is, when someone is waiting to be admitted, those are the small things that we don't think about, and how important they are. Though I just think about going to college my first time and what that experience was, and I knew no one, and I was committed to making a life change, not only student loans commitment, but those changes and those. I mean, you're talking about making a life commitment theoretically, and so just in that moment and the fear that one may have. And so I think it's just important for us to be there, be in the moment, be knowledgeable about that individual. And they're just not another number. They're just not another name. They are a person. And so that story of yours is just really cool.
Sharita, thank you. And I'll just share this really quickly because Shannon, I was thinking of, just your take and your perspective. And, SAMHSA talks about recovery, like they've gone back and done several, revisions to recovery, and their working definition of recovery right now is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And in that discussion, there ain't one word about abstinence, and it can be just as applicable to somebody who is actively using as somebody who is really hoping to, sustain their own recovery. The other thing, as I was listening to all of you just share about, how you come at some of the outreach and the engagement piece, and Sharita, you were sharing some examples, Ashley, you too, one of the things that I remember in some work I did with Shannon's organization several years ago was working with a gentleman who he and I went to a federal FHQC, or like I always get that wrong, but a federally qualified health center. And this was at a time when the ACA had just started allowing the Medicaid expansion. And the challenge that was happening for the LA Community Health Project was that folks were going, now that they had insurance, going to primary care providers and being so stigmatized and so mistreated that they just decided, you know what, we're not doing that. Well, if we need to, we'll go to the ER again, because we're not going to put ourselves in that position. And this federally qualified health center, the way that they approached this, and the staff at the LA Community Health Project, it was amazing. If you were in active addiction, you could go in and you could sit down and somebody would accompany you there. And if you needed to use, as Shannon pointed out, you need 4 or 5 shots a day if you're using something like heroin. And so, the last thing you want to do is leave after you've waited for several hours at this health center to see somebody, and you have to leave if you need to use. Well, what they did there was took a person into the bathroom, showed him the right stall, told him to clean up after they were done. Don't leave anything behind. I'll hold your seat so that you don't miss your appointment. And I almost cried when I heard that, because had somebody done that for me at the height of my active addiction, I don't know, my faith in humanity would have been restored. And so, it was just super powerful, because that process of change definitely improved the health and wellness of individuals who are in active addiction. So I wanted to share that, because it was just a really powerful example of SAMHSA's recovery definition being applied to people who may not necessarily be, considered in recovery, but it still mattered. So with that, let me just talk about this for a second. Actually, I had a couple of questions too that came in the chat, and I don't want to avoid them or miss them. One of the questions that I saw in the chat was, is there any experience using any of the contingency management tools to help encourage ongoing treatment and recovery within a program, or to really assist and facilitate additional progress with early recovery? Thoughts, folks? Any contingency tools or management tools that you're using?
Where's that question again, Steve?
Are you using, are you using any contingency management tools that would help a person advance along their recovery journey, or, maybe find a reason to actually show up for services?
Well, actually, back to the recovery goal planning. Once members accomplish that goal, then they have the opportunity to create another goal. And so it becomes a working document that they participate in. It's not staff coming up with their goals. For example, we had an individual, his goal was to have a car. And that was a year-long goal, but along the way, we had to work with him to pay off his tickets he had. And so he paid off his tickets. He was able to get his driver's license again. He was able to start practicing driving again. And then he purchased his car. And so, as I mentioned along the way, having those small wins. But one thing I want to just mention when we talk about meeting people where they're at, we should never be in a position to say that the door is closed. And so even with our federally funded programs, we never say a person has aged out or graduated out of a program. Once you're a member, we call our individuals members. Once you're a member for life. And so you may drop out of sight for a couple of years, you're doing well, and you may just want to stop by and see how things are doing, or even just come back to a meeting. The door is always open. And so I think that's very important.
That's fantastic. Thank you. Shannon or Ashley, anything to add?
We give out speed pipes when we have them, and that keeps people coming around. That's contingent on whether or not we have the pipe.
Understood. Thank you. All right. So let me. There was another interesting audience question, and one of the things I just wanted to quickly share is something I saw in the chat too, and this individual had posted that housing first can be problematic when there has not been any work to build capacity behind maintaining the housing, time management, vocational skills, et cetera. And I just wanted to say to whoever shared that that comment, that's spot on, and that it's one of the reasons that Housing First takes such a beating, because people often try to implement that as the panacea. This is gonna end our homeless problem in our community, and that's just not accurate, because if you do not set that program up appropriately and you have that capacity behind it, what you've basically done is damaged the sort of perception of Housing First. And I've seen this occur in my own community, and made the idea of moving people through this process of Housing First a lot more difficult. So thank you for that comment. And let me go back to our big list of questions here. There's been a lot of public discourse lately around police reform and reallocation of some funds that went to law enforcement, instead funding other community programs such as home services or a potential needle exchange. Have any of your programs started new services or hired new staff as a result of any of this reallocation that might be happening? Just a thought.
In LA, Measure J reallocated $150 million of the LAPD's insane budget, and so far we've had the Alternatives to Incarceration work group meetings, where as a broader Los Angeles community of community-based organizations, we voted on where we would like the funds to go, to propose that to the Board of Supervisors. But so far, those funds have not been distributed, but we do have plans for what we would do with them.
Shannon, thank you. That's awesome. I didn't know any of that was happening. That's great news. So you're just waiting now for a decision on how that money.
Yeah, and there was a huge amount of talk about harm reduction. LA really needs to improve its harm reduction services in general, and that was a talk among all those organizations. So
Thank you. Thank you. Sharita or Ashley, anything happening for you guys?
Yeah, no, not
Not down
here.
south. Sorry about it.
Yeah, not here.
Not there yet.
But right. But what we would know that, at our organization a number of years ago, I decided that many organizations do not have the capacity of grant writing. And so we've been very successful in partnering and being that entity that writes the grant. Establish those collaborations. If we were always waiting for a grant to come and no one wrote the grant, we wouldn't get one, right? And so I think that collaborations is just very important to in this field of work that we do. There will never be enough, I believe, funding to address the work that we do on a daily. And so you have to be smart, you have to be creative, you definitely have to network and partner with people. One thing I was thinking about when we're talking about the homeless population, one thing that we do is, and it's so inexpensive, yet it makes a great impact. We've purchased toiletry kits. So when you think of someone who's homeless under the bridge, clearly they don't have toothpaste. clearly they may not have a disposable washable rag. And so in our toiletry kit, we're able to have toothbrush, toothpaste, a comb, disposable rags, those type of things, because we know we're not going to be able to reach everybody. But we also provide those to some of our treatment providers. Once again, when we're talking about people who are leaving treatment, sometimes they literally have nothing. And so having at least call them toolkits also, I just think that's important. And as providers, we should force ourselves to think further, to think a step, ahead. What are some of the needs that can be really inexpensive things that we can do to help someone, whether it's if you have a transit system, asking, can you have a certain number of bus tickets, knowing that you have a number of people that you serve that have transportation issues. And so we it takes a village. And I just think that we have to continuously think about how we can create this network to help people who need our help.
Sharita, thank you. I've worked with Ashley in the past. I know that, I even shared that sometimes, I just did a radio interview this morning with an organization in Massachusetts. And I said in that radio discussion, well, I hope my old boss isn't listening, because I used to give out these all-day bus passes when it was really hot, just so that people could ride around in some air conditioning. Because you have to adapt and overcome, right?
Steve, we still do that.
That's good to know.
We still do that. We give out bus passes. We give out, and I mean, we do give out tents and sleeping bags and propane and things to keep people alive in the elements, right? Like, a lot of people think that encourages people to stay on the streets, and it merely just protects their lives, and it protects them from dying. And we are an organization that spends a lot of our grant dollars on getting supplies so that people can stay alive while we work with them and while we serve them.
Right.
Really, really lovely. And that's wonderful, Ashley. I'm really glad to hear it's still happening. So listen, folks, we're almost out of time, and we can talk on this all day. There's no doubt in my mind. But here's one of the things that I just want to throw out to all of you. And this is really important, I think, from the Opioid Response Network's perspective. We know that the United States doesn't just have an opioid problem. It doesn't just have a substance use problem. It has an addiction problem. And it's the addiction challenges. It may not be, an opioid. It could be gambling. It could be sex. It could be food. It could be a whole bunch of things. But what this comment is in the chat was this. In many communities, opioid use is devastating communities of people living unhoused. I mean, I'm really proud of whoever used that language, because I don't see that very often. But in central Iowa, methamphetamines is the preferred drug. What suggestions, initiatives, or treatments beyond safer injection and typical harm reduction do you suggest? So, 60 seconds to each one of you. Any thoughts around that? Let's start with Shannon. Shannon, 60 seconds. What do you think?
Just say it one more time. Beyond safe injection, beyond.
It's just harm reduction and safe injections. Is there anything else that you suggest that folks pay attention to or do?
I mean, I think honestly, the most important thing is talking to people about their use and having people. I mean, when you talk about safe injection, letting people use in front of you, telling them not to go in the bathroom if they're at your house. You got a friend injecting. Tell them to do it on the couch. Use a paper towel. Don't bleed. But just breaking down the barrier and having the conversation open so that they can come to you if ever they want to recover. They'll talk to you about it. They'll never talk to you about it if they can't talk to you about their addiction in the first place.
Beautifully stated. Ashley or Sharita?
I
60
think
seconds.
So what's been said, but also understanding information and debunking myths, because one thing that is big is disability assistance. So sometimes through the SOAR process, sometimes if someone is like actively using, they can also get benefits if they also experience a mental illness. And so the reason I bring this up right now is because there's a myth out there that, you know, and oftentimes mental health and substance misuse go hand in hand. And so if we could help them get resources and get connected to care and insurance and all of that stuff, then maybe they could get closer to wanting to work on their recovery. You know, so I say that research and look there, it's a myth that you can't be getting both, like you can't be using and be getting this particular resource. So I wanted to add that in.
Super helpful. Thank you. The SOAR program is terrific. And Sharita, you
Yeah,
got
I mean,
60 seconds.
okay, you know, ditto to both my my partners in crime, no pun intended. But you know, once again, I just think as providers, we owe it to the people we serve to be educated, knowledgeable, have access to resources, and continuously do that. Because if we accept the idea that people have individual needs, then we know we have to have this whole toolkit of different tools and to be able to serve people as they come to us. And so I actually have a number of staff who are, you know, SOAR certified. I have a staff person who is, you know, certified outreach worker to help people access healthcare and insurance. And so you basically have to arm yourselves and you know, I want to leave people's path to recovery to their decision making, but I get to control the resources and support that I can give to them.
Perfectly stated. Thank you. So folks, listen, thank you all for just a powerful discussion. I hope that you know, our participants found value. The chat has been really alive, and it's been very exciting just to watch people respond to everything that you guys have been saying. So as we get ready to leave, you know, I just want to share, please, folks out in the audience, join us for our next panel discussion. This one will be on creating impactful interventions and recovery supports for youth and young adults. It'll occur Tuesday, May 25th from 2 to 3. And again, Ashley, Sharita, and Shannon, thank you so much both for your time today and for the work that you're doing for my brothers and sisters, because we need you guys. We need you bad. Thank you. Have a great day, everybody.